of the spectrum, there is anaplastic throat cancer with a mortality of 99%. It's not the survival anymore. We also learned in last 10 years, the radioactive iodine ability goes down. However, the PET positivity goes up. So if you are dealing with a poorly differentiated or anaplastic throat cancer, the PET scan is of great help. Now, I just want to show you this complicated slide, but it is very important to understand the biology and the molecular analysis of anaplastic throat cancer. And here you will see a variety of different molecular analysis in differentiated thyroid cancer, where you get the RAS, the BRAF, which is present in about 60% of the patient, the RET fusion. In follicular thyroid carcinoma, it's mainly RAS, and in Hurther cell carcinoma, again it is RAS. As you go on to from well differentiated to poorly differentiated and anaplastic thyroid cancer, clearly there is a loss of differentiation here, and majority of these may be BRAF and TERT positive. And you can see here the P53 is positive in more than 60% of the patients. So this understanding of the progression of disease is very critical in the management of anaplastic throat cancer. Now we can target, based on the molecular analysis, a particular mutation, either RAS, BRAF or TERT, and attack the tumor and get the best results. Whenever we talk about anaplastic throat cancer, there are many differential diagnoses. Poorly differentiated, very rarely the medullary thyroid carcinoma can be confused with anaplastic, lymphoma, melanoma and sarcoma. They can be easily confused because these are all small cell tumors. And there it is very important that we have a dedicated and devoted pathologist who can distinguish. And now with the immunohistochemistry, it is not very difficult to distinguish what is a good thyroid cancer and what is a bad thyroid cancer. There are three different types of anaplastic thyroid cancers. The de novo, which is giant and spindle cell anaplastic thyroid cancer, where the prognosis is extremely poor. Then comes the well-differentiated thyroid cancer transforming into anaplastic, which happens with over a period of time. If the patient has recurred, it is not uncommon to see the transformation from well-differentiated to anaplastic. And the last, which is very rare, a benign goiter transforming into anaplastic, that's pretty rare. It is quite likely there is a small element of well-differentiated thyroid cancer which has transformed into anaplastic. This is a classical example. This is a young lady who had best of her life. She went on a cruise 3 weeks before, came back with this big swelling with airway problem. And soon after I saw her, within a matter of an hour, she got intubated because she could not breathe because of the vocal cord paralysis and enormous compression on the neck. Remember, good judgment comes from experience. However, in a life, experience comes from bad judgment. So what are the issues that we're going to talk about? Making a correct diagnosis is very important. And there are different ways. The classical way is the fine needle biopsy. But in the olden days, the fine needle was not very easy to distinguish between different types of thyroid cancers. And now with the immunohistochemistry, with the good pathology and cytology, we can use the fine needle as a definitive diagnostic tool. In the olden days, we used to do core biopsy, very common. Open biopsy is extremely rarely used now because the tumor literally fungates through the skin and it is not easy. You have to take the patient to the operating room, airway problems. Liquid biopsy, I don't think we have big data on that, but that will be the future. Do the DNA analysis of the serum and see if you can make a diagnosis of anaplastic thyroid carcinoma. We'll talk about the types of anaplastic thyroid cancer, the role of surgery, where do we go with that, and then we'll talk a little more about the airway and what is the role of tracheostomy, because there is the current debatable subject. Now, if you look at the definition of the anaplastic throat cancer and the TNM staging, as you know very well, all the anaplastic throat cancers are stage 4 tumors. The stage 4A is quite rare, which is intrathyroidal anaplastic throat cancer. That happens only in 10% of the patients. Majority of them are having distal metastasis, what we call stage 4C tumors. Now, if you look at the survival, the overall survival is extremely low, but it is best in intrathyroidal tumors, the worst in tumors 4C, tumors with distal metastasis. Now, it is interesting to understand the development by the American Thyroid Eye Association with the guidelines. This was the paper that was published in 2012. I happened to be one of the co-authors in the national recommendations. There were 65 recommendations with 126 references. This changed quite a bit in 2017 to 2021, and you can see here, this is the second task force by the American Thyroid Association. I am here. Now, very important, whenever there is a picture or the photograph to be taken, make sure you stand in the middle of the photograph. It's very important. You can see this was taken in 2017, and in 2021, it took about 4 years to publish these guidelines. It is an enormous work by a large number of people. You can see here a large number of people. There were 4 surgeons. I happen to be one of them with the recommendations from surgical point of view. There were 31 recommendations. For the first time, we came up with 16 good practice statements. And now you will see here, there were 330 references compared to about 150 in the previous edition or previous version. Now, what are the steps in the management of anaplastic throat cancer? The first and the foremost is establish the diagnosis. The second, very important, engage the team. Whenever we see a patient with anaplastic throat cancer, there is a flurry of emails goes in the institution, and everybody knows there is a patient with anaplastic throat cancer coming in. The MD Anderson called this facilitating anaplastic throat cancer specialized treatment. That is, they call it FASTIM. At Memorial, we do the impact study on this, which we'll talk a little more. This is the specimen that goes to the pathology department for impact analysis. It is integrated mutation profiling, actionable cancer targets. That's why we call this impact. Determine the extent of the disease. The surgeon's role is to evaluate extent of the disease. And more importantly, to make a decision, is there a role for surgery today or in the beginning? Majority of these patients come with advanced disease, locally advanced disease, or distal metastasis, and are not candidates for surgical intervention. Evaluate the surgical options, surgical decision making, the simple question, to go or not to go. That's the decision that the surgeon has to make. And the last but not the least, as we did in both the anaplastic guideline studies, that you need to have the ethics department involved. And the hospice and end-of-life care is also very important. It is also important for the patient and the family to understand that this is an advanced disease. We don't have a definite modality to treat you, and the life expectations. I think that's very important. What are the patient and the family expectations? And now I'll show you in the next 20 minutes how we have made progress with BRAF mutation. And again, I just wanted to show you how the clock moves very fast. Everybody gets involved, including the surgeon, the